Thanks, Elise. I appreciate that introduction. As Elise mentioned, my name is Andrew Beharrie. I'm one of the orthopedic surgeons at Summit Medical Group. I specialize in sports medicine. And tonight I'll be talking about common rotator cuff injuries and treatment for those injuries. I'd like to start by thanking Mary and the Fairlawn Library, as well as Elise and the marketing department at Summit for making this possible. And I'd also like to thank everyone who came out virtually for the talk. Before I get started, I'd like to give some background on myself. I was born in Kingston, Jamaica, where I lived until I was 8 years old, and moved to Brooklyn, New York, where I grew up. I always had a strong interest in math and science and medicine from a young age, and I went on to MIT for undergrad, where I majored in electrical engineering and biomedical engineering. From there, I went on to Harvard Medical School and followed that with a residency in orthopedic surgery at the University of Pennsylvania, and then a sports medicine fellowship at Lenox Hill Hospital in New York City. And I've been in practice now for 15 years. Summit City MD is a very large multi-specialty group. We have 7.4 million annual patient encounters with over 1,600 providers in over 80 specialties, including orthopedics. We have greater than 215 locations in New Jersey, New York, as well as Oregon. As an overview for this talk, I just want to highlight some of the common causes of shoulder pain that patients will present with. Probably the most common is shoulder bursitis, also referred to as impingement syndrome. We also have rotator cuff tears, frozen shoulder, and shoulder arthritis. I'll focus on the first two as well as the last because they can all be related on a spectrum of symptoms that patients will present with. Before we discuss rotator cuff tears, it's helpful to look at the anatomy. As we all know, the shoulder is a ball and socket joint. There are three main components to it. We have the ball of the shoulder, which is at the top of the arm or humerus bone. We have the socket, which is a portion of the scapula or shoulder blade. And there's also a roof to the shoulder joint. And the roof is formed by the acromion, shown here, as well as a portion of the collarbone or clavicle. The shoulder joint is an inherently unstable joint. Some people compare it to a golf ball sitting on a tee, and you can see that when a golf ball is on a tee, there's not a whole lot of coverage of that ball. And so while the shoulder has the most range of motion of any joint in the body, it also comes at the expense of being the least stable. So besides the bony anatomy, which we see here, the shoulder relies on a group of muscles to provide stability to the joint and allow us to have a functional joint. Those group of muscles are the rotator cuff. The rotator cuff comprises four muscles. So we have the subscapularis, which is the rotator cuff in the very front of the shoulder, shown here. We also have the supraspinatus, which sits at the very top, and it's shown in this area of this diagram. We have the infraspinatus, which is more posterior in the back of the shoulder, along with the teres minor. Now, these four muscles, when they attach to the ball of the shoulder, they sort of come together and we say coalesce sort of into one unit. And we refer to that as the rotator cuff. It's almost like the cuff of my shirt. And the rotator cuff serves a number of functions. It allows us to raise the arm overhead. It allows us to also rotate externally and internally. But one of the important functions of the rotator cuff is it helps to keep the ball of the shoulder centered and stable within the socket. The acromion is important, and the acromion morphology or shape can be one of three things. The first is a flat or type 1 acromion, and a type 1 acromion shown here is one where there's the most space for the rotator cuff. So the rotator cuff sits in this space, and when you have a flat acromion, that maximizes that space. We can also have a type 2 acromion, which is curved, and you can see that with that curve, there's slightly less space for the rotator cuff. But there's a type 3 where there's a hook to the acromion. You hear us referring to patients having a bone spur in the shoulder. That bone spur is really when they have this hook that points down into the rotator cuff. And you can imagine that when it digs down into the rotator cuff, over time, it can cause damage. Another important part of the shoulder is the subacromial bursa, and we have bursal sacs in many joints. The bursa is basically a thin sac of fluid that serves as a low friction interface. And in the shoulder, the subacromial bursa, and subacromial just refers to the fact that it sits below the acromion. The subacromial bursa provides a low friction interface for the rotator cuff and cushions the rotator cuff, especially as the arm is raised overhead so that there's less impingement from the acromion. So with impingement syndrome, what we see is that the rotator cuff and the bursa, as you lift the arm overhead, those two structures can get pinched underneath the acromion, as well as this ligament shown here. And with overhead maneuvers, the space for those structures become a lot less. With impingement syndrome, patients typically present with pain in the upper arm, and the pain can be anywhere from the front to the side and back of the shoulder. The pain tends to be worse with overhead maneuvers, and you can also have night pain that disturbs your sleep. When it comes to impingement syndrome, the biomechanics, again, as I highlighted, is an impingement or a compression of the bursa and the rotator cuff as the arm is brought overhead, typically as the arm is brought above the horizon, greater than 90 degrees, because that causes the greatest amount of pinching of those structures. This is an animation showing what happens with impingement syndrome. So as the arm is being raised overhead, the rotator cuff shown here and the bursa, which is not shown but sits right here, can get pinched underneath the acromion. And as we age, we tend to develop these bone spurs on the acromion, and those bone spurs can push down onto the rotator cuff and the bursa, cause inflammation, and over time can cause tearing and damage to the rotator cuff. On physical examination, patients typically will have pain when the arm is raised overhead, such as in this diagram. Pain can also be reproduced when the arm is raised and abducted and then rotated in, because that causes impingement of the rotator cuff against the roof or acromion. But patients will often have pain as well as you lower the arm from an overhead position or pain with reaching out. When patients present with complaints consistent with impingement syndrome, workup in the office typically involves getting an x-ray. The x-ray may be completely normal, or the x-ray may also show some calcium deposits in the area of the rotator cuff that can also predispose patients to having pain. We refer to that as calcific bursitis. MRI of the shoulder is typically done if patients have chronic pain or if they present after an injury. And what we can see here is that on this MRI slice, which shows the ball and socket of the shoulder, as well as the rotator cuff, this is the acromion, and we can see that there's a little hook in the acromion and it's pushing into and causing damage to the rotator cuff. Treatment for impingement syndrome is typically conservative, and that involves usually the use of NSAIDs or non-steroidal anti-inflammatory drugs such as Advil, Motrin, Aleve, Celebrex. Home exercises and physical therapy are also a mainstay of treatment because the goal is to strengthen the rotator cuff. As I mentioned before, the rotator cuff helps to center the ball in the socket. If you have a weak rotator cuff, the ball actually starts to ride high, and that can decrease the space for the rotator cuff when you raise the arm. So strengthening the rotator cuff actually helps to provide more space for the rotator cuff and decreases the risk of impingement. Cortisone injections can also be very effective by decreasing the inflammation in the rotator cuff. These are basically a steroid that is injected into the bursa and decreases the inflammation of the bursal sac. Patients who are treated without surgery but continue to have pain over the course of 6 to 9 months can be candidates for surgery. And the surgery that's done for impingement syndrome is an arthroscopic one, so it's minimally invasive. So we look inside the shoulder with a camera. We make 3 or 4 small incisions, look inside the shoulder with the camera, and with the camera, through the camera, we can remove any inflamed bursal sac. We can remove bone spurs as well. And this picture here is showing an instrument called a burr that's used to shave down a bone spur. Following surgery, patients are placed in a sling for 10 to 14 days. We begin range of motion exercises as patients can tolerate, and physical therapy is usually done for approximately 6 weeks. Most patients can return to most of their activities by approximately 3 months. Next, we'll discuss rotator cuff tears. Most rotator cuff tears are occurring in patients over 40, and these tears are usually degenerative in nature. It's wear and tear from repetitive impingement. Part of the reason that the rotator cuff is more prone to tearing as we get older is that the blood supply to the rotator cuff decreases with age. And so when there's not adequate blood flow and you have repetitive impingement against the acromion, tears will happen slowly over time. And this image shows a tear in the rotator cuff as shown here. Patients, though, can present with a rotator cuff tear after an injury or trauma. So if you fall onto the outstretched arm, that can cause a tear. And people who have chronic inflammatory disease processes, such as rheumatoid arthritis, can have damage to their rotator cuff over time that leads to tears. Patients with rotator cuff tears typically present similarly to those with impingement syndrome. So you have pain in the upper arm. The pain is worse with overhead motion. You can have night pain that disturbs your sleep. But the classic finding with rotator cuff tears is weakness. And you can have weakness with lifting the arm as well as rotating the arm, because each of the rotator cuff muscles serves a specific function in terms of motion. So again, patients will have findings on exam similar to impingement syndrome, but you may have weakness with forward flexion, which is raising the arm forward overhead, pain or weakness with external rotation, or weakness with internal rotation. The workup for rotator cuff tears is similar. X-rays can be completely normal. MRIs, though, that's the gold standard in terms of diagnosing a rotator cuff tear. So these two images on top shows different slices, we call them, through the shoulder of a patient with a rotator cuff tear. The slice to the right shows the ball and socket along with the rotator cuff, and we can see the rotator cuff attaching onto the ball. In this slice, however, we can see that there's a tear in the rotator cuff. Instead of being attached to the ball, it's pulled away, and then now there's a gap between the tendon and the bone. Not all rotator cuff tears, however, need to be treated with surgery. Non-operative or non-surgical treatment for rotator cuff tears is indicated in some instances. One of those is people with what we call partial rotator cuff tears. A partial rotator cuff tear is a tear that does not go all the way through the tendon. So this first image here shows the ball and socket of the shoulder with the rotator cuff. The rotator cuff is attaching onto the ball. And here we see a defect in the rotator cuff. And this is what's called a bursal sided tear, because it sits on the side of the rotator cuff against the bursa, which sits right here. You can also have a tear on the other side of the rotator cuff, and that's called an articular sided partial tear, because it sits against the articular surface, we call it, of the joint. These partial tears do not require surgery and can be treated conservatively. Patients with small rotator cuff tears, even if they go all the way through the rotator cuff tendon, those patients can also be treated without surgery. And then you also have people coming in with chronic tears. The tearing in the rotator cuff can happen so slowly over time that most patients don't realize that there's an issue until the tear is so large and retracted that it really can't be fixed. So in those instances, we don't fix those tears. We treat those patients without surgery. And then you have another group of patients who have medical issues who may not make them ideal surgical candidates, and those patients would be treated without surgery as well. Patients who require surgery on the rotator cuff are ones who tend to have bigger tears. So if you have a tear greater than 2 centimeters, if you are someone who was treated without surgery, but you don't do well, you continue to have pain, you have weakness, you can't sleep, you can't do your normal activities of daily living, that would be an indication to do surgery. And if you have a younger patient, especially who had an acute injury, a fall where they tear the rotator cuff, those patients are typically indicated to have repair of the rotator cuff right away. The state of the art when it comes to rotator cuff repair, today it's done arthroscopically, so it's a minimally invasive procedure. Again, we're looking inside the shoulder with a camera. You get 4 or 5 small incisions around the shoulder. We look in with the camera, and with various instruments, we can reattach the rotator cuff to the bone. The camera allows us to see the entire shoulder. We can actually see the shoulder much better arthroscopically than you can if you try to do a big open procedure. With the older techniques where you have a big scar, you would have to detach the deltoid, remove the deltoid in order to look inside the shoulder. With an arthroscopic technique, we no longer have to do that, and that allows for less pain. There's also less risk of infection. This is an animation showing a repair of the rotator cuff. Here we see the ball and socket of the shoulder, and the rotator cuff is torn and pulled away from the bone. We use an instrument called a burr to prepare the bone for the implants of the anchors. Here we have an anchor going into the bone. That anchor has sutures that come out from the anchor, and then those sutures are passed through the rotator cuff using a special instrument. So we pass these sutures through the rotator cuff. Here we see a second anchor being placed. Once this anchor is placed, similarly, we pass the sutures through the rotator cuff, and then we tie them sequentially, one after another. And you can see as we do so, we bring the rotator cuff down onto the bone and form a union of the rotator cuff back to the footprint from which it was torn. Following surgery, patients are immobilized in a sling. And the reason we need to immobilize the shoulder is that once we reattach the rotator cuff, it's not healed as yet. So if you start moving your arm right away, the rotator cuff will fire and will pull against the repair, and that can cause the repair to fail. So for the first 6 weeks, you're in a sling, but you're allowed to move your elbow and your wrist so they don't get stiff. Physical therapy started at 6 weeks, and initially all we do is just range of motion to prevent the shoulder from getting stiff. And then after 6 weeks, we can begin strengthening so that we can rehab the rotator cuff muscles. Most patients have full recovery by 6 months. In cases of larger tears, it may take a bit longer, can be up to 9 months. But usually once you fully recover from a rotator cuff repair, there are no restrictions. You can resume all your activities. There are a subclass of patients, though, who have chronic rotator cuff tears. And when you have a chronic rotator cuff tear as shown here, over time, if that tear is not fixed or patients present years down the road where the tear has become so big and so retracted that the tendon is pulled far away from the bone, those patients are not candidates to have a repair. And so you treat them without surgery. Some of those patients, though, over time will develop arthritic changes of their shoulder. As I mentioned, the rotator cuff is important for keeping the ball centered in the socket. If you don't have a functioning rotator cuff, the ball will ride high, will go up underneath the acromion, and that's what we're seeing in this picture. Well, that chronic process of the ball riding high can lead to arthritis in the shoulder. When patients have arthritis in the shoulder, you have loss of motion. You present with stiffness. You have pain with activities. And the pain, it can be deep and gnawing. You can have night pain that disturbs your sleep. This image here shows a normal shoulder that over time becomes arthritic, and you lose the cartilage on the ball and socket, and that's what we call arthritis, essentially. Patients who have very large chronic tears in the rotator cuff present with pain, but they also present with significant weakness. We have a gentleman here with a tear in his left rotator cuff that's been there for a long time. It's a large tear, it's chronic. He's trying to raise his arm and he can't do it. We refer to that weakness as pseudoparalysis. When patients present with chronic rotator cuff tears, the x-rays might be normal, or they may show, as I mentioned, that the ball is ridden high and is now sitting right under the acromion. So instead of the ball sitting right against the socket, it's now proximally or elevated with respect to the socket of the shoulder. Over time, that leads to arthritis. And this is a patient that has end-stage arthritis due to a chronic rotator cuff tear. We refer to it as rotator cuff arthropathy. The treatment for rotator cuff arthritis is conservative initially. So as with impingement syndrome and rotator cuff tears, we can try injections, we can try non-steroidal anti-inflammatory medications such as Motrin or Relieve, we can modify activities and physical therapy. Physical therapy can be helpful because even though we may not have a functioning rotator cuff, there are other muscles that can help to compensate, such as the deltoid muscle. So we work on strengthening the deltoid, and that can allow patients to have some forward elevation and functional activity. But not everyone does well with conservative treatment. And the patients who don't do well, those patients are then indicated for shoulder replacement. Now, there are two types of shoulder replacements. One is an anatomic replacement shown here. And the reason it's called an anatomic replacement is that we try to restore the anatomy. So here we have the ball of the shoulder. You replace the ball with a metal ball that's attached to a stem that goes into the arm bone. And there's a plastic socket. Because it's plastic, you can't see it on the x-ray. But basically, you put the socket on the socket and the ball on the ball. There's something called a reverse total shoulder arthroplasty or reverse shoulder replacement, and that is shown here. And it basically is, as the name says, you put the ball on the socket and the socket on the ball. And the reason it's important to reverse it is that without a rotator cuff, the ball is going to ride high. So if you put a standard anatomic shoulder replacement, it's going to fail because the ball is then going to push up and it's not going to sit in line with the socket. By reversing things and putting the ball on the socket and the socket on the ball, the arm, the upper arm gets captured by this ball and there's no way that it's going to ride high. So a reverse total shoulder arthroplasty is indicated for someone with arthritis that's developed from a chronic rotator cuff tear where the ball is migrated up and you now have arthropathy or arthritis. There are other indications for reverse total shoulder arthroplasty, but not really within the scope of my discussion here. When it comes to the surgery, patients typically stay overnight, one night. The anesthesiologist will generally do a nerve block, and that nerve block will provide good pain relief into the evening and sometimes into the next morning. There is a strict post-operative protocol that is followed, and when the surgery is done, patients are placed in a sling, and you're going to be in a sling for a period of 3 to 4 weeks without any movement of the shoulder. And that allows the soft tissues to quiet down, that allows the inflammation to quiet down. During those several weeks, you're allowed to do elbow and wrist range of motion. And then at 3 to 4 weeks, we begin physical therapy to begin range of motion and strengthening. This is an image of a woman who underwent a reverse total shoulder arthroplasty of the right shoulder. And looking at her, you wouldn't be able to tell which side she had surgery on. She's able to lift the arm overhead. Full recovery, though, although most patients get good function by about 3 months, full recovery can take up to a year. So I'd like to thank you all for coming for this talk. This is basically an overview of different types of rotator cuff issues. Again, my name is Andrew Beharrie. I'm one of the orthopedic surgeons at Summit Medical Group. My office is in Paramus on Route 17 South. Thank you.